Okay, let's jump right into this. We are looking at a massive paradigm shift today, one that literally impacts every single patient who goes to sleep on your operating tables. For decades, fluid management has been this foundational cornerstone of anesthesia and surgery, right? Yet somehow it is still one of the most hotly debated, confusing topics in our entire field. In this explainer, we are going to unpack the deep physiological mechanisms at play, decode some highly conflicting clinical trial data, and synthesize the absolute latest international consensus that is fundamentally rewriting how we manage intravascular volume.
Hello, anesthesiologists, critical care specialists, and clinical researchers. Thank you for your dedication and care for patients during perioperative care. Today we will learn about fluid therapy during the perioperative period. Bonjour à tous, anesthésistes, réanimateurs et chercheurs cliniques. Merci pour votre dévouement et votre attention envers les patients en période périopératoire. Aujourd'hui, nous aborderons la fluidothérapie périopératoire. I want to start by acknowledging something we all face. We all know the daily, frankly stressful, struggle with the incredibly narrow therapeutic window of fluid administration. You are constantly balancing the severe risks of hypovolemia against the equally dangerous, insidious consequences of fluid overload. It is a tough balancing act, but we're going to break down how to master it.
To cut through the clinical uncertainty, our agenda is straightforward. We'll hit history and fluid physiology, compare crystalloids versus colloids, dive deep into the restrictive versus liberal debate, explore goal-directed fluid therapy, discuss ERAS and special situations, and wrap up with the brand new 2024 POQI-XI consensus guidelines. Section 1. History and Fluid Physiology. Let's look at how our understanding of fluid care has evolved. For decades, the pendulum of fluid management has swung wildly. In the past, the liberal fluid tradition completely dominated. This was driven by the old theory of massive third-space fluid sequestration. We essentially flooded patients to prevent hypovolemia. Then, the landmark 2003 Brandstrup trial shocked the surgical world. It showed a massive 30 to 51% reduction in complications when fluids were restricted. This really birthed the modern era of strict zero-balance targets. But then, the pendulum swung too far. In 2018, the RELIEF trial revealed that strict zero-balance restriction actually increased acute kidney injury. So now, in 2024, the POQI-XI guidelines are pushing us away from these rigid, one-size-fits-all labels and moving us toward highly individualized, physiology-guided therapy.
The core concept here is a U-shaped complication curve. The central conflict we manage in the OR and the ICU is that both extremes cause profound organ failure. On one end, excessive fluid administration doesn't just sit in the vessels. It leaks, leading to tissue edema, worsening congestive cardiac failure, respiratory failure, and actually impairs GI healing. On the other end, uncorrected major fluid losses lead to hypoperfusion, tissue hypoxia, and acute kidney injury. It is a razor-thin therapeutic window. And remember, for your patients with chronic kidney disease or heart failure, their fluid tolerance is vastly lower. That window shrinks even further, making precise volume assessment absolutely crucial.
To understand volume assessment, we have to talk about the Frank-Starling mechanism. This curve relates left ventricular preload to stroke volume, and it dictates our entire clinical response. When a patient is on the steep, ascending portion of this curve, administering a fluid bolus will significantly increase their stroke volume and cardiac output. We call this patient fluid responsive. But once you hit the flat, plateau portion of the curve, giving more fluids does absolutely nothing to improve hemodynamics. The extra volume just drives up venous pressures and leaks into the interstitium, causing pure iatrogenic harm. And here's the terrifying clinical reality that we all need to internalize. Only about 50% of hemodynamically unstable patients are actually fluid responsive. Giving fluids to the other 50% is literally just causing harm. So how do we actually figure out where a patient sits on that Starling curve? Historically, we relied heavily on static parameters, things like central venous pressure, PAOP, or just watching urine output. But comprehensive reviews like ELEA and colleagues in 2023 have definitively proven that static parameters are highly inaccurate predictors of fluid responsiveness. Variables like changing vascular resistance, poor ventricular compliance, and shifts in intrathoracic pressure completely distort static readings. Because of this, they've been largely abandoned in modern guidelines for fluid titration. Instead, dynamic parameters are now the gold standard. Metrics like stroke volume variation and pulse pressure variation use the cyclic hemodynamic changes induced by positive pressure mechanical ventilation to accurately predict if a patient will actually respond to a fluid challenge before you give it. Section 2. Crystalloids versus colloids.
Let's talk about choosing the right fluid for the job. We have to address the saline problem. Normal saline, 0.9% sodium chloride, is actually completely unphysiologic. Its massive chloride load causes renal afferent vasoconstriction and hyperchloremic metabolic acidosis. The data here is staggering. The 2018 SMART trial of over 15,800 critically ill adults, along with the SALT-ED trial studying more than 13,300 non-critically ill patients, definitively proved that buffered, balanced crystalloids, like lactated ringers or Plasma-Lyte, significantly lower major adverse kidney events compared to normal saline. Now, you might point to the 2015 SPLIT trial, which showed no difference in AKI between the two, but it's crucial to note that the patients in the SPLIT trial received very small volumes of fluid. When large volume resuscitation is needed, the evidence unequivocally demands buffered crystalloids to protect your patient's kidneys.
Now, what about colloids? They have a theoretical appeal, right? That 1 to 1.3 volume sparing advantage over crystalloids, but the clinical reality just doesn't support their routine use. Extensive reviews, including Lorente in 2015 and Himming in 2020, highlight that synthetic colloids, specifically hydroxyethyl starches, or HES, are strongly associated with an increased risk of acute kidney injury, a higher need for renal replacement therapy, and even increased mortality in critically ill patients. Consequently, the POQI XI guidelines say absolutely do not use HES for volume replacement. And albumin? While it's great for preserving colloid osmotic pressure, multiple large surgical ICU trials show it offers zero patient outcome or mortality improvements over saline, and it comes at a vastly higher cost. So routine use of albumin for intraoperative fluid administration is just not recommended anymore.
Section 3, Restrictive versus Liberal Strategies, Finding the Optimal Fluid Balance. Okay, let's dive into this massive debate, because this has generated immense confusion in clinical practice. Why did earlier trials say restrictive is great, but later trials say restrictive causes kidney failure? The conflicting data is actually a terminology problem. A brilliant 2019 commentary by Miller and Pierce breaks this down perfectly. In the landmark 2003 Brand strep trial, the restrictive group that had amazing outcomes actually received enough fluid to have a 1 kilogram postoperative weight gain. Their liberal control group was literally flooded, gaining around 4 kilograms. Fast forward to the 3,000 patient relief trial in 2018. In relief, the restrictive group was pushed to a strict zero balance, gaining only 0.3 kilograms, and they suffered significantly higher rates of acute kidney injury. The relief liberal group gained about 1.6 kilograms and did better. Do you see what happened? The successful restrictive group of 2003 essentially matches the successful liberal group of 2018. The takeaway, backed by recent systematic reviews like Messina 2021 and Josiah 2026, is that a mildly positive balance is optimal for major elective abdominal surgery. Strict zero-balance Ross approaches might just be too restrictive for the kidneys.
Section 4, Goal-Directed Fluid Therapy, Moving Toward Physiology-Guided Care. So, if fixed volume strategies are flawed, what do? We use goal-directed fluid therapy, or GDFT. This is where we stop guessing and start objectively measuring. The core principle is titrating fluids to specific real-time hemodynamic goals. Imagine an algorithm using stroke volume variation. If SVV is greater than 12 or 13%, it proves the patient is on the steep part of the Starling curve. This objectively triggers a small fluid challenge, usually 250 to 500 milliliters. But if SVV is low, meaning the patient is fluid non-responsive, and they are still hypotensive with a low mean arterial pressure, we absolutely do not give fluids. Instead, we initiate vasopressors. This flow-based monitoring completely removes the guesswork and individualizes the resuscitation. And the evidence for GFD is very robust. By utilizing technologies like esophageal Doppler or minimally invasive arterial waveform analysis, GFD continuously optimizes stroke volume while actively preventing interstitial edema and pulmonary congestion. The classic 2012 Corcoran meta-analysis showed that GFD, compared to standard liberal therapy, reduced pneumonia by roughly 30%, significantly cut renal complications, and reduced hospital length of stay by 2 full days. More recently, the 2021 Messina 20-year meta-analysis, which looked at 21 RCTs in over 2,700 patients, confirmed a significant drop in overall postoperative complications, with a pooled risk difference of -0.10. Now, while it may not drastically reduce overall perioperative mortality, GFD is absolutely essential for safely navigating that narrow therapeutic window, especially in high-risk patients. Section 5, ERs and Special Situations. Integrating fluid management into modern care pathways. Goal-directed fluid therapy doesn't operate in a vacuum. It is a central pillar of enhanced recovery after surgery, or ERAS pathways. As Manning and Hemming have outlined, proactive fluid stewardship within ERAS means shifting completely away from replacing presumed massive deficits to actively maintaining homeostasis. Preoperatively, we've abolished those archaic NPO after midnight rules. We now encourage clear fluids up to 2 hours before surgery to prevent baseline dehydration. We also avoid routine mechanical bowel preparation because it aggressively depletes intravascular volume. Intraoperatively, we deploy GDFT, and postoperatively, we rapidly de-escalate IV fluids in favor of prompt oral intake. These steps, working synergistically, accelerate recovery and drastically slash complications.
Of course, we have to tailor these pathways for special populations. In pediatric anesthesia, Lorenz's 2025 review highlights a major shift. We've moved past old formulas like the 4-2-1 rule, opting for a strict 1-hour clear fluid fasting guideline and relying entirely on isotonic crystalloids to prevent hyponatremia. In the ICU, modern fluid management follows a 4-phase framework: resuscitation, optimization, stabilization, and active de-resuscitation, where we deliberately pull accumulated fluid off the patient. For patients with chronic kidney disease, their delayed fluid clearance makes them incredibly vulnerable to volume overload, demanding hypervigilant, continuous, dynamic monitoring. Furthermore, the surgical approach itself matters. Open surgeries trigger massive evaporative losses and inflammatory fluid shifts that you simply don't see in laparoscopic cases, necessitating totally customized fluid targets.
Section 6, the POQI Consensus Guidelines. Let's look at the absolute latest recommendations.
So, where does all this leave us? The 2024 Perioperative Quality Initiative, or POQI, gives us our blueprint. Published by Osterman and colleagues in the BJA, this is a massive consensus utilizing grade methodology and a modified Delphi process across experts from 17 countries. The level of agreement is striking. There is nearly universal consensus for prioritizing buffered crystalloids over normal saline and for adopting short 2-hour preoperative fasting. Most importantly, explicitly addressing the fallout from the RELIEF trial, the consensus officially recommends aiming for a mildly positive 1 to 2 liter fluid balance by the end of major cases to protect the kidneys. They have formally abandoned strict zero balance dogmas. The POQI guidelines also get highly specific, demanding individualized therapy depending on the surgical scenario. For major, elective, non-cardiac surgery, again, the target is a 1 to 2 liter positive balance. For our transplant surgeons in kidney transplants, buffered crystalloids are strongly recommended over saline, specifically to prevent delayed graft function. For thoracic surgeons doing long resections, the rules totally invert. You must avoid a positive fluid balance in the first 24 hours to prevent post-pneumonectomy pulmonary edema, keep them dry. In neurosurgery, you must strictly avoid hypotonic solutions to prevent cerebral edema. And for cardiopulmonary bypass, the panel strongly recommends against using albumin or synthetic colloids for priming the circuit. It is all about the right fluid in the right amount for the right patient.
Synthesizing all of this evidence, the big clinical takeaway is clear. The old debate between liberal and restrictive fluid therapy is effectively dead. Rigid one-size-fits-all volume labels are dangerous. The path forward requires integrating goal-directed fluid therapy within ERAS frameworks, prioritizing dynamic parameters like SVV over static ones like CVP, and universally adopting balanced crystalloids while discarding the routine use of synthetic starches and albumin. Looking ahead, the future of perioperative care lies in entirely new frontiers. We're talking about leveraging individualized biomarkers and AI-based predictive hemodynamic monitoring to finally completely eliminate the clinical uncertainty of fluid administration.
So I leave you with this final, provocative thought. Knowing what we know now, knowing the undeniable physiological superiority of buffered crystalloids and the proven renal dangers of rigid zero-balance restriction, how will you rewrite your own institutional protocols tomorrow? How will you champion the integration of dynamic monitoring to ensure every single drop of fluid you administer is physiologically justified? It's time to stop guessing and start measuring. Thank you for joining this deep dive, and I truly hope this empowers your clinical practice, whether you're in the OR, the ICU, or conducting the next wave of clinical research.